Just give me thumbs up. I just check the feed, YouTube का feed. I think I am live. Hello, 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 hello. Hello, hello, hello to everyone. Am I audible? Visible to all of you? Just give me thumbs up. And the wait is over for this most demanded section. काफी दिनों से चल रहा था कि सर इमेज बेस रख दो, इमेज बेस रख दो, इमेज बेस रख दो. मैं क्या चलो आज वो घड़ी आ चुकी है. हेलो 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 टू ऑल. एम ऑडिबल? विजिबल तो है, ऑडिबल. मुझे खुद की आवाज भी नहीं सुनाई दे रही. अच्छा मैंने बंद कर रखा. ओह माय गॉड. सो वी आर जस्ट लाइक आज 3 तारीख हो गई है और एग्जाम है 6 तारीख को. आप सब लोग के एडमिट कार्ड आने की आप सभी को बहुत बहुत बधाई, बहुत बहुत बधाई प्यारे दोस्तों. और अब हम एक स्टेप पास जा चुके हैं. पहले सबसे ज्यादा टेंशन यही थी कि एडमिट कार्ड आएगा कि नहीं आएगा, और परमात्मा की कृपा रही है हम सब पे और हमारा एडमिट कार्ड आ चुका है, जिसकी आप सभी को बहुत बहुत बधाई. और 6 तारीख को पास होने की एडवांस में बधाई. तो आज हमारे बीच में जो महागुरु पधारे हैं, मैं उनके बारे में 2 बातें बताना चाहूंगा. उनका नाम हम सबने बहुत जोरों शोरों से सुना हुआ है, बट उनका चेहरा देखने का सौभाग्य जो है बहुत कम लोगों को प्राप्त हुआ. डॉक्टर कमल केवी सर, हमारे महागुरु कमल केवी सर नाम की एक बुक आती थी, उनके ऑथर हैं, जिन्होंने एमसीक्यू बुक बनाई थी एफएमजीज के लिए और वो काफी प्रसिद्ध हुई. इसका चर्चा आप लोग अपने सीनियर से भी पूछ सकते हैं. दूसरा, जब कोविड का टाइम आया था, डॉक्टर कमल केवी सर वो पहले शिक्षक बने थे जिन्होंने बच्चों को फ्री ऑफ कॉस्ट पढ़ाने का संकल्प लिया था, जिस ट्रेंड को फॉलो करते हुए और भी लोगों ने फिर इसको आगे बढ़ाया. बट सबसे पहले जो इस चीज को लेकर के आगे बच्चों की हेल्प के लिए, एफएमजीज की हेल्प के लिए आए थे, वो हमारे कमल केवी सर थे. तो अब मैं चाहूंगा कि जब मैं सर को इस सीट पे बुलाऊं तो जोरदार इस चैट बॉक्स के अंदर जो है भर जाना चाहिए आई विल पास, आई विल पास, आई विल पास. और पूरी चैट में आप लोग सर के साथ बने रहिए. सर ने अपने एक्सपीरियंस से सबसे ज्यादा इंपॉर्टेंट क्लिनिकल इमेजेस विद क्वेश्चन आपके लिए चूज करा है, जो 6 तारीख को आपके एग्जाम में बहुत ज्यादा हेल्पफुल रहेगा. And my dear friends, I'll not take much time and I want to welcome one and only Dr. Kamal Kv sir. Sir, please पधारिए और अपना फोन में एक बारी प्लीज वो चैट बॉक्स खोल लेंगे. क्या बात है सर. तो सर आ चुके हैं हमारे बीच. ये बच्चे जो हैं, क्या बात है, क्या बात है. ये सब माइक लगा लीजिए आप. काफी उत्सुक हैं ये आपसे मिलने के लिए. अभी जब कभी बीच में बंद करना हो माइक तो ये सर जी माइक का ये बटन यहाँ से हम बंद कर लेंगे और स्क्रीन आई थिंक यहाँ से बंद हो जाती है. ठीक ठीक मैं यही हूँ. ठीक है सर. यूट्यूब में आपको खोल के देता हूँ बच्चे जब तक आप इसको देख लीजिए.
चलो नमस्कार बच्चों, राम राम. सबसे पहले तो मैं पारस भाई का बहुत बहुत धन्यवाद देना चाहूँगा कि उन्होंने मुझे ये सौभाग्य दिया कि मैं आप सब लोग के साथ कुछ ज्ञान की बातें कर सकूं. और अगर आप लोग कॉमेडी नाइट्स विद कपिल देखते हो तो आपको पता होगा कि हर अभिनेता अभिनेत्री की बड़ी ख्वाहिश होती है कि वो कपिल शर्मा के स्टेज पे जाए. तो उसी तरह से अगर एफएमजी की बात होती है तो हर फैकल्टी की बड़ी दिली ख्वाहिश होती है कि वो पारस भाई के चैनल पे एक बार जरूर आए. ठीक है, तो इसलिए पारस भाई के लिए भी जोरदार तालियां बजा देना. तो ज़्यादा समय नहीं लेते हुए मेरे ख्याल से पढ़ाई की बातें शुरू की जाएं. और मैंने कुछ इम्पोर्टेंट क्वेश्चंस जो इम्पोर्टेंट टॉपिक से बने हैं वो रखे हैं आपके लिए. और मैं ऐसा आशा करूंगा कि ये आपको एग्जाम में थोड़ा हेल्प करेंगे. ठीक है. और इसमें जैसे मैंने एक पहले क्वेश्चन रखा है, तो जब भी आपको इमेज बेस्ड कोई क्वेश्चन आता है तो उसके लिए आपकी अप्रोच ये होनी चाहिए कि आप सबसे पहले इमेज देखो. क्वेश्चन पढ़ने से पहले आप सबसे पहले इमेज देखो. क्या पता इमेज देख के आपको एक आइडिया हो जाएगा क्वेश्चन में क्या पूछे जाने वाला है. तो उससे आपको ये जो जैसे मैंने फर्स्ट क्वेश्चन एक्चुअली इसी कॉन्सेप्ट पे रखा है. तो अगर आप क्वेश्चन देखोगे तो इसमें 5 लाइन दिए हुए हैं, बट अगर आप सीधा इमेज पे आ जाओगे तो मेरे ख्याल से बहुत सारे बच्चे इस इमेज को देख के एक आइडिया लगा सकते हैं कि इस इमेज में दिखाया क्या गया है. ठीक है. तो अगर आप इस इमेज में देखोगे तो बहुत ही क्लियर कट आपको स्नो स्टॉर्म अपीयरेंस मिलेगा. ठीक है. तो इसमें आपको बहुत क्लियर कट स्नो स्टॉर्म अपीयरेंस मिल रहा है, ठीक है। और जब भी आपको स्नो स्टॉर्म अपीयरेंस मिल रहा है अगर यूएसजी में, तो आप बहुत क्लियर हो सकते हो अपने मन में कि ये शायद एक मोलर प्रेगनेंसी का अल्ट्रासाउंड है, ठीक है। तो एक हमने सबसे पहले, जब भी आपको क्वेश्चन मिलता है केस हिस्ट्री के साथ अगर इमेज हो, तो प्लीज सबसे पहले आप इमेज देख के एक आइडिया लगा लो, तो उससे आपको पता चल जाएगा यार ये क्वेश्चन मैं सॉल्व कर सकता हूँ या नहीं कर सकता हूँ। अगर वो आप सॉल्व कर सकते हैं तो ही उस क्वेश्चन को शुरुआती स्टेज में समय देना, अदरवाइज उसको आप स्किप कर सकते हो। तो ये अल्ट्रासाउंड देख के आप समझ सकते हो कि ये स्नो स्टॉर्म है, मोलर प्रेगनेंसी है, फिर आप क्वेश्चन पे जा सकते हो, ठीक है। तो अगर हम क्वेश्चन पे जाएंगे तो हम देखेंगे यहाँ पर एक 36 ईयर्स की लेडी है, G1P0, मतलब एक बार प्रेग्नेंट हो चुकी है, बट उसका जो फीटस था वो 28 वीक जो लिमिट है प्रेगनेंसी की उसको क्रॉस नहीं कर पाया, और पहली बार प्रेगनेंसी हुई, सॉरी। और जब वो आई तो उसको हमने फर्स्ट ट्राइमेस्टर में देखा तो उसको वेजाइनल ब्लीडिंग चल रही थी, ठीक है, और साथ में नोजिया भी था और पेल्विक पेन भी था। तो जब हमने उसका वो देखा तो उसका जो यूट्रस था वो उसकी एक्सपेक्टेड एज से हाइट में ज्यादा था। तो जो उसका फंडल हाइट थी यूट्रस की वो उसकी गेस्टेशनल एज से ज्यादा थी, और साथ ही साथ फीटल के हार्ट रेट के टोन्स भी नहीं थे। इसका मतलब कि कोई फीटल कार्डिक एक्टिविटी इसमें नहीं मिल रही थी। तो जब आप ये देखोगे तो आप एक क्लियर कट डायग्नोसिस बना लोगे कि ये एक मोलर प्रेगनेंसी का केस है, और अल्ट्रासाउंड भी उसकी ही उसको कंफर्मेशन देता है। तो मोलर प्रेगनेंसी के लिए आप सीधा बोल सकते हो कि जो बीटा एचसीजी लेवल्स होंगे वो नॉर्मल से थोड़े ज्यादा होंगे। सो बीटा एचसीजी लेवल्स विल बी हायर देन नॉर्मल, ठीक है। तो यही है कि जब आपको कोई भी इमेज बेस्ड क्वेश्चन मिलता है तो सबसे पहले आप इमेज देखो, फिर आप क्वेश्चन पे जाओ, तो आपको बहुत क्लियर रहेगा सॉल्व करने के लिए, राइट। फिर नेक्स्ट क्वेश्चन पे चलते हैं। इसमें भी ऐसी दिया है कि एक 20th वीक का स्टेशन के साथ एक प्रेगनेंसी लेडी आई है और उसको एक एनोमली दिख रहा है यूएसजी में। तो अब इसमें आपको क्या आप सोच सकते हो, तो अगर आप ये इसका यूएसजी का इमेज देखोगे तो आपको थोड़ा सा दिखेगा कि थोड़ी सी आंखें थोड़ी बड़ी बड़ी हैं, ठीक है। और अगर आप उसका स्कैल्प को देखना चाहोगे तो स्कैल्प भी थोड़ा आपको छोटा सा दिखेगा। तो ये बहुत ही क्लियर कट बनता है इमेज। Okay, right. Okay, so this is a clear-cut image of USG of anencephaly, in which the scalp thing is not clearly developed, and the eyes are pretty big, and it looks like a frog eyes sign. So this is a clear-cut USG of. Okay, I'll try to be in English here, no problem. Right. So this is a clear-cut USG of anencephaly. Yes, wonderful, Ishan. So this is anencephaly, right? Then if we move on to next question, now we have to identify the heart chambers. So okay, Raghu, welcome. Yes. So yes, that is anencephaly. Perfect. Now we'll move on to the next question, and here we can see that the heart chambers have been shown. So this one is the right atrium, this one is the right ventricle, this one is left atrium, and this one is left ventricle, right? And posteriorly this one is aorta. Clear? So these are the heart chambers which you have to identify. So if someone is asking you about the label 1, you can simply say that label 1 is right atrium. Clear? So this is right atrium, right ventricle, left atrium, and left ventricle. So this is how the chambers are visualized during imaging studies. So yes, Graz, it is right atrium. Clear? So next question, and here also you have an image, a peripheral blood smear image, and the clinical history. So the question starts with a female who is a strict vegetarian, and the peripheral blood smear has been given, right? So I think most of you can, just looking at this particular word, strict vegetarian, most of you can think that it is a case of vitamin B deficiency. Yes, that's right. But what is being shown on the peripheral blood smear? Now, this is a neutrophil which is being shown here, right? So this is a neutrophil, and yes, if you can count the lobes of the neutrophils, they are like 1, 2, 3, 4, 5, 6, right? So you can see here there are 6 lobes, and as per like the normal neutrophil, it is multilobulated and the number of lobes are nearly 3 to 5. So this is normal, right? So anything more than 5, you can say it is a case of hypersegmented neutrophil, right? So this is what is being shown in the image is actually hypersegmented neutrophil. Clear? So there are more than 5 lobes, and that what is for, yes, very good, Raghu. So this is what the peripheral blood picture of vitamin B12 deficiency is, right? So like image based questions, you have you can have question which can be derived from the image, or you can derive your answer from the clinical history as well. So on one aspect, these questions are quite easy to solve provided you know the concept, right? So this is the concept behind this particular peripheral blood smear, right? I think now this is very basic question and most of you can answer it quite easily. So we have to identify what is the plane A. Now if you look at the plane A, this one is the plane A, and it is dividing the body into 2 equal halves. One half is anterior and the another half becomes the posterior. Clear? So if you have a half which is dividing the body into 2 equal halves, anterior as well as posterior, your answer will be, what your answer will be if there is a plane which is dividing the body into 2 halves, anterior and posterior, that is coronal, right? So that is the coronal plane, okay? And the sagittal plane, yes, Ishan, perfect. And the sagittal plane, it divides the body into 2 equal halves, that is right and left halves. Clear? So sagittal will be, yes, everyone is right. So that is coronal A, and the label B is actually the sagittal, which is dividing the body into 2 equal halves, right and left. Okay, so that is about the basic plane. And C is of course the transverse. So C here is transverse, dividing the body into upper and lower half. Chalo. Next question. Can you identify the artery which is being palpated in this image? So which artery is palpated here? So if you look here, the palpation is being done on the dorsum of the foot, right? So dorsum of the foot, and this is the place where we palpate dorsalis pedis artery, right? So this is dorsalis pedis artery. Clear? So this is the site of palpation of dorsalis pedis artery. And this is one important, yes, Ishan, you are right. This is one, yes, Raghu, perfect. And this is one important place where we do palpate this artery, particularly in cases of Berger's disease, right? So this is dorsalis pedis. Now, no one should mix it up with posterior tibial, and posterior tibial is palpated behind the medial malleolus. So this is for posterior tibial. Please don't mix up. This is posterior tibial, and this is for dorsalis pedis. Clear? Right? So this is, yes, so dorsalis pedis. Now, next question. Now we have to look at an image and we have to identify the peripheral blood smear. Now look at the shape of the RBCs. What you can see here, you can see the shape of the RBCs, they are spherical, right? So the RBCs, they are looking spherical, and there is loss of central pellar, right? So these are spherical cells in shape and loss of central pellar. Because usually if you look at the RBCs, if they are like this, there has to be a central pellar area. But here we don't see any central pellar. So this is a classical, yes, this is the classical peripheral smear of hereditary spherocytosis. Clear? This is hereditary spherocytosis, and I think most of you can answer it. That there is defect in spectrin, or if not, spectrin is not given. If it is not given, you can also look for ankyrin. So any of the true proteins can be the answer here, right? So this is hereditary spherocytosis. Yes, Kajal. Now, next question. Which tarsal bone is shown in the image? So this is which tarsal bone? Now this is navicular, clear? This is navicular, and anterior to navicular we have medial cuneiform. Posterior to navicular we have talus, okay, and lateral to navicular we have the cuboid, right? So we have the cuboid, and then yes, I think everyone can identify the navicular quite easily. So this is navicular, clear, in front of talus. Now the help has been given in the form of the use of this particular instrument in case of labor room. So can you identify what instrument is this? So if you look at the instrument properly, one side is blunt, another is little sharp. So this is the episiotomy scissor, right? So this is the episiotomy scissor, and I think, yes, Kanishka, very right. Kanishka, sorry. And I think most of you must be knowing what actually episiotomy is during the delivery of the head of the baby, right? So this is the episiotomy scissor. Now, moving forward to the next question, what is the location of the foreign body in the given X-ray, right? So what is the location of foreign body? Now, this seems to be a coin, yes, and this is a coin which has been swallowed, so it will go into esophagus. Clear? So this is a coin which has been swallowed and it will go into esophagus, right? Now, see, yes, most of you can think that way. This is tracheal impression, right? This is tracheal impression, but behind trachea we have esophagus, and it is not that easy for a coin to go into trachea, right? So that is the catch here. It might give you an impression as if it is in trachea, but a coin usually cannot go into trachea that easily as compared to esophagus, right? So esophagus is a better answer over here. Yes, it gives you an impression as if it is in trachea, but it is not easy for a coin to go into trachea as such, right? So please remember that. So for that particular reason, I think esophagus is a better answer here. Clear? So think that way in practical sense. Clear? Chalo, next question. Now, in the next question, we have been given some auscultatory areas, and you have to just correlate like which of the option given is correct. Thank you, Kapil. Right? So which of the option correctly correlates with the numbering of the auscultatory area? Ashish, this is AP view. Okay. Right? So now here you need to know the areas. Now one is aortic, right? 2 is pulmonary, 3 is herbs, 4th is tricuspid, and 5th is mitral. Clear? So this is the sequence. First is aortic, second is pulmonary, third is herbs, 4th is tricuspid, and 5th is mitral. Now, looking at these options, which one you see is the right? We have to choose the right statement. So which one is right for you? Yes, so you can clearly mark out that 2 is pulmonic area. Clear? So out of the options, option A is the correct one. 2 is pulmonic area. Yes, Raghu, you are absolutely right. Aortic, pulmonary, herbs, tricuspid, and mitral. Clear? Now, look at the microscopic view of glomeruli and what diagnosis you can make looking at this image. Now, what you can see here, you can see crescent formation, right? You can see crescent formation. So this is the crescent formation, and I think most of you must be knowing what crescent formation, what condition is related to crescent formation. Very good. So this is also known as crescentic GN, which is another name for rapidly progressive GN, right? So this is how you can just look at the glomerulus and you can just mark out the crescent, which is very clearly shown in this image, although in the description also you have the word crescent, right? Otherwise, if this is not given to you, you can just look at the formation of the crescent, and that is sufficient enough to label it as a case of rapidly progressive glomerulonephritis. Clear? Now, next question. Look at the image first. That will give you an indication. Look at these two fingers. I think this is quite enough to give you an idea that what the case is going to be, right? Okay. So now let's go on to the question as such. Yeah. Right. So here a case of leprosy had come to the OPD with there is a deformity. Now, if you get a case of leprosy and with this kind of presentation, is the video? Yes, Raghu, right. So very clearly you can see that there is, clawing of the little finger and there is clawing of the ring finger. So yes, very good. So this is known as partial clawing. Clear? I think most of you must be knowing this. And we also know that most commonly involved nerve in leprosy is ulnar nerve. Clear? So combining these two facts, you can clearly reach up to the answer that your answer would be ulnar nerve. Clear? So that way you can say that the answer is ulnar nerve. I think all of you can answer this. Right? Now, a patient presented to the OPD with following findings, and you can see here, you can see multiple petechial hemorrhages. Okay, so you can see petechial hemorrhages here. Clear? And also you can see bleeding from gums. I think the moment you see this kind of picture, it's very clear for you the diagnosis is scurvy here, right? So bleeding gums, some periosteal hemorrhages. I think the periosteal hemorrhages, or I think yes, this is very clear-cut case of scurvy, and you can go for assessment of plasma ascorbate levels, which is vitamin C level, right? So this is a clear-cut case of vitamin C deficiency, that is scurvy. Clear? So moreover, whenever you get a case of gum bleeding, start your answer. Initially you should think of scurvy first, right? So think of scurvy first. Later on you can think of other differential diagnoses, but start with scurvy, right? So this is a typical picture for scurvy. Now, next question. What we have been image has been given, and you have to identify what images are being carried by the tract which are marked as number 2. Now, this is the tract which has been marked as number 2, right? So, any idea what is carried by this particular tract? Now, what tract is this actually? Number 2 is, what is number 2? Tract number 2 is, what is tract number 2? Anyone? Dorsal column, very good. So tract number 2 is dorsal column, which is also known as posterior column. Okay, and yes, dorsal column, again we have two parts. Like if we see like this is medial part, and then we have the lateral part. Right? So suppose again you can draw the same on the other side as well, like this. So this is the medial part, and this is the lateral part. Okay. So the medial part, this is fasciculus gracialis, right? So this is fasciculus gracialis, and the lateral part is fasciculus cuneatus. Clear? Now the sensations. Now the fasciculus gracialis is for lower limbs, and fasciculus cuneatus is for upper limb. Clear? So the modalities which are carried by dorsal column is proprioception. Very good. So this is fasciculus cuneatus. Now, which muscle is shown in which blue color? So which muscle is this? I think this is, yes, Raghu, you are absolutely right. Absolutely right. So I think most of you must be knowing this answer. Which muscle is this? It's one of the muscle which is very commonly asked, right? So the one which is in blue color. Yes, anyone? Very good, very good. So this is genioglossus, right? And I think most of you must be knowing that it is also known by one another name, and that is safety muscle of tongue. Clear? So yes, very good, Poonam, right? So this is genioglossus. Now, which structure is shown in red color? Yes, any idea which structure is shown in red color? Very good, very good. So this is the caudate nucleus, okay? This is the caudate nucleus. Yes, very good. Then this is, what is this? This is putamen, right? This is putamen. And deep to putamen we have globus pallidus, antenna. This is globus pallidus. And yes, very good. And this area is the internal capsule, right? So this area is internal capsule, and lower down here we have thalamus. Okay? So this is the thalamus, right? Yes, putamen and globus pallidus forms the lentiform nucleus. Very good, Raghu. Right? So this is how the arrangement is there, right? So caudate nucleus. If you go laterally, then this is internal capsule. This is all internal capsule. Then lateral to this is putamen, right? So this is putamen. And deep to putamen, we have the globus pallidus, interna and externa. Okay. And then medial most is thalamus, right? So this is thalamus. Clear? So please remember this arrangement. Okay. We have question on this many number of times, right? Now next question. Again, if you look at the histology, you can think of like what kind of the appearance of RBCs is there. Now we can go with the question statement. Now here a very important clue is given that the person is having long standing hemorrhoids, right? So the person is having long standing hemorrhoids. Now he developed weakness and lethargy. Hemoglobin is also less. What can be your diagnosis? Now, I think if you can just look at the images, the options, just look at the options, that will give you much more idea. See, if there is long standing hemorrhoid, it means long standing hemorrhoids leading to blood loss, and that will lead to iron deficiency. Clear? So simple, if you go like that with the case history, and that is evident by low hemoglobin, that is written over here. And what we actually see in this case is hypochromia, right? And microcytosis. Clear? So that way you can make a diagnosis of iron deficiency anemia. Clear? Yes, Kapil, you are right. So this is iron deficiency anemia. So that is how sometimes you have to, evaluate the options to reach up to a particular answer. Clear? Sure. Now, I think this is CT scan. Everyone can identify. Very commonly asked and very, I think there shouldn't be any confusion in this. Right? So yes, I think everyone can answer this. This is a typical CT scan of extradural hemorrhage, right? So this is extradural or epidural hemorrhage, and yes, the answer has to be middle meningeal artery. Okay? So the answer has to be middle meningeal artery. Okay? Chalo, I think this is not much of problem. Now, next question. Uh, okay, yes, everyone is right. This is Hagar sign, right? And what actually, okay, so yes, this is Hagar sign, and this is, you can see there is a very good, very good. So on bimanual examination, we can see the softening of cervix, right? So this is bimanual examination, and we can see the softening of cervix. Very good, Musin. Softening of cervix. Clear? Very good. So this is Hagar sign. Next question. which nerve is marked as number 2. So you have to identify which nerve is this. So identify the nerve number 2. Number 2 is, yes, ulnar. This is ulnar. Very good. Okay. So this is ulnar. Number 2 is ulnar, right? So this is ulnar, right? And you can see it is passing behind the medial epicondyle, right? So this is the medial epicondyle, right? And it is passing behind the medial epicondyle, right? And just look at the course here. This nerve is supplying this much area. Okay? So this nerve is supplying this much area. So which nerve is, this is ulnar nerve, okay? So this is the ulnar nerve. Clear? Now number 1 is, this is median nerve. Okay, number 1 is median nerve. And if you look at the territory of the median nerve is supplying this area. So this is 3.5. This is 1.5. Clear? So this is median nerve. This is ulnar nerve. Right? So next question. Now look at the ECG here. Yes, Raghu, you are absolutely right. Look at the ECG here. A patient presented with chest pain, breathlessness and syncope. ECG is shown here. What should be done now? No, this is the easiest ECG to identify. Easiest. No, this is a case of here there is no okay, no QRS complex T wave, right? So you cannot mark out anything in this given ECG, right? So this is a ECG of ventricular fibrillation, right? This is an ECG of ventricular fibrillation. Right? And in ventricular fibrillation, what you need to do? You have to do CPR with defibrillation. Right? So This is a typical ECG of ventricular fibrillation. You will not be able to see anything, and you will go for CPR and defibrillator, right? Yeah. The next question. So now the next question, and here we have to identify the structure number 10. So structure number 10. This is pons. Okay. This is pons. Clear? So this is pons here. Then 11 number is medulla. Then 13 number is spinal cord. Then 14th is fourth ventricle. 12 is cerebellum. Yes, right. So this is a typical sagittal view where you can easily mark out the pons, which is in the front of the diamond-shaped fourth ventricle. So this is the fourth ventricle. Clear? So this is pons. Next question. Now, if you look at the image, I think you can get the answer. The keyword written is tortuous veins. And if you go with the history, there is swelling, mild pain. DFA काम करें उस पे ले लें वन ड्राइव पे उस पे कर देते हैं इस क्वेश्चन के बाद वन ड्राइव पे लेते हैं ठीक है 2 मिनट का ब्रेक ले लो मैं चाय भी लेता हूँ जिसको 2 मिनट का ठीक है इस क्वेश्चन पे 2 मिनट का ब्रेक दे दो बच्चों को अभी दे दो हाँ ओके गाइस 2 मिनट ब्रेक विल कम बैक ठीक है ओके द व्हील्स आर
माइक और सब
Okay, welcome dear students. Now I think things might be much better So here, I think you can clearly see that this is a case of okay. So here, there is a male with swelling and pain in the scrotal sac, and this swelling decreases on lying down and increases on standing, right? And therefore, it tends to be more on the evening time. And the classical word is bag of worms, and the picture is also perfect. So this goes in favor of varicocele, which is the tortuous dilatation of pampiniform plexus. Yeah, right. So this is varicocele. Yes, Raghu, absolutely right. Chalo, moving forward to the next question. Now, while doing this procedure, there is tearing of umbilical cord. So, what should be done now? Now, this procedure is actually controlled cord traction. Okay, this is controlled cord traction, and while doing this, if there is tearing of umbilical cord, say somewhere here, then you have to manually remove the remaining part of the umbilical cord along with the placenta. So manual removal of placenta has to be done. Yes, absolutely right. Everyone is right. Now moving forward to next question. There is a patient with meningitis, lumbar punctures were done, and this is the appearance, gross appearance, right? So this is the gross appearance, and this is the microscopy, right? So this is the microscopy, and along with that, it is written that there is sugar is less, proteins are high, and there is mononuclear leukocytosis, right? So that is clear cut picture of tubercular meningitis, right? So this is actually known as cobweb appearance, right? So you can see this is, you can see some, this is cobweb appearance, right? So this is cobweb appearance, and moreover, this is lymphocytes which has been increased, right? So this is TBM. Very good. Cobweb. Chalo, next question. What is the action of this muscle which is shown in green color? This muscle is, no, this is the spine of scapula. Clear? And the muscle which is above the spine of scapula will be, of course, supraspinatus. Right? So this is the supraspinatus muscle. Right? And the action of supraspinatus muscle is initiation of abduction of shoulder, that is 0 degree to 15 degree of shoulder abduction. Yes, Raghu, you are absolutely right. Right? So this is supraspinatus. Now I think this condition is very easy to identify. You can clearly see there is a Codman's triangle here, right? So this is the Codman's triangle, okay? Right? So here we can see there is formation of Codman's triangle, and that is very suggestive of the Codman's triangle here. Okay, so this is Codman's triangle here, and the moment you find this word Codman's triangle or any appearance like this, your answer has to be osteosarcoma. Yes, very good. So next question. A lady had a history of neck swelling which moves on deglutition, and right, so this is a classical case of swelling moves on deglutition plus protrusion of tongue. If you have this kind of swelling which is in the midline below the hyoid bone, yes, this is a typical thyroglossal cyst. Very good. So in the midline, just below the hyoid bone. Okay, thyroglossal cyst. Now, next question. A patient has swelling around the knee joint and there is soap bubble appearance on the x-ray. And when you see this kind of picture, I think the moment you find this word, soap bubble appearance, your answer is very clear. This is a case of, also on histology, what you are seeing, these are giant cells. Clear? And these, and the remaining are these mononuclear cells, which are the actual tumor cells. Clear? Yes, so the answer has to be, very good Kapil, this is giant cell tumor. Okay? Giant cell tumor. So, right. Next question, I think you can see a clear-cut torsion of the testes. So this is testicular torsion, right? So you can see testicular torsion. Clear? Not to discuss much in that. Now, a patient has gross abdominal distension and then a test was done. Which clinical test is this? You can see stroking finger, then palpating finger, and then there is the hand has been kept so as to avoid any transmission across the abdominal wall, right? So this is the fluid thrill test, right? So this is the typical fluid thrill test, right? So this hand is kept to prevent transmission of vibration across the abdominal. Clear? So this hand has to be kept there. So this is a fluid thrill, not shifting dullness. In shifting dullness, we have to turn the patient and we will percuss then, right? So that is shifting dullness is different. This is fluid thrill. Okay, no problem. So I think this is quite easy to identify. This is the typical fistule pupil. So this is fistule pupil, and this suggests that there is additions between posterior iris and anterior lens. Clear? So this is a picture of acute anterior uveitis. Yes, Shubham. Perfect. Now, next question. Yes, Ishan, right. Not in glaucoma. Anterior uveitis. Okay. Now, next question. Identify the label 1. You have to identify what is this here. Right? So we can see there is a communication between this is uterus, okay, this is bladder, this is vagina. Clear? So we can see that there is a communication between the vagina and the urinary bladder. Very good, Shubham. So this is a case of vesico-vaginal fistula. Vesico word is for urinary bladder. So there is a communication between the urinary bladder and vagina, right? And this is especially seen with obstructed labor. So VVF. Now, what is being done here? You can see something is done in relation to the cervix. So this is actually cerclage operation. This is cerclage operation, or what is known as Schrodinger's procedure, and that is done for cervical. Yes, Raghu, absolutely right. So cerclage operation that is done for cervical incompetence. Very good, Shubham. So this is for the cervical incompetence, which presents as second trimester abortion. Clear? So yes, Schrodinger's, McDonald's, you can do anything. So this is cervical incompetence. Now, whenever you see any case of case history with HIV, something related to oral cavity, always go for Candida. So that is oral thrush. So no more discussions on this question. Now, what you see in this X-ray, Here you can see a straight line, something like this. And then you can see opacity in this area, right? So something like this. So this is, you can see opacity here. Now what is this? Very good, Raghu. Very good, Raghu. So this is pneumonia, and which is also known as consolidation. Clear? So this is consolidation. Very good. Right? So that is consolidation. Now this is a virus with, you can see, 2 copies of RNA, right? With you can see integrase, then reverse transcriptase, GP120. You can say this is HIV, right? So no discussions on that. So next question. A patient with progressive anemia, there is enlargement of liver spleen, there is prominence of malar eminence, and peripheral blood smear is given. I think the moment you see the clinical picture and the peripheral, you can directly jump onto the diagnosis of thalassemia, right? So there is extramedullary hematopoiesis that gives this prominence of maxilla or malar region. There is enlargement of liver and spleen. Spleen is most usually enlarged, yes. And here you can see the typical target cells, right? So these are the target cells, right? So this is a classical picture of thalassemia. So please remember, this is how you will see a peripheral blood smear of thalassemia, right? Target cells. Clear? Yes, this is chipmunk facies or hemolytic facies, right? Target cells. Very good. Next question. Now here you can see this is also known as invertogram. This is also known as invertogram, and we have held the legs are here and the head is here. So we have held the baby in an inverted position, so that is known as invertogram, and this is done for imperforate anus. Okay, so this is done for imperforate anus, and you can see here you cannot mark out the anal opening, so it is somewhat like this. So imperforate anus. Okay. So next question. Now what you see here, you can see the classical dendritic ulcer. Okay. So this is the typical dendritic ulcers of herpes simplex keratitis. So this is dendritic ulcers. Clear? So this is herpes simplex keratitis. Okay. So you can see this is right. Yes, HSV ulcers. Very good. Okay. Right. So next question. In ultrasound, what you can see here there is, this is scalp edema. Okay. Scalp edema, right? And scalp edema is, or skin edema, that is seen in RH isoimmunization or what you call RH incompatibility. Okay, so this is scalp edema. Please remember this. Or sometimes you might have skin edema. Clear? That is because of collection of fluid. So you may have this yes, RH incompatibility. Okay. So next question. Now what you see in this particular ECG, if you look here, you will see S1, okay, S1, Q3, T3. So with this S1, Q3, T3 pattern of ECG, where you find this? Very good. This is pulmonary embolism. So S1, S wave in lead 1, Q wave in lead 3, and T wave in lead 3, right? So this is S1, Q3, T3 pattern. I think this everyone can identify. This is conical forward projection of cornea, and that is known as keratoconus. It doesn't need. Yes, Raghu, absolutely right. Now, HIV/AIDS patient with diarrhea, straightforward, you have to mark your answer as cryptosporidium, right? So this is cryptosporidium. The moment you have this word, HIV with diarrhea, cryptosporidium, right? Now, let's move on to next question. Which landmark is this? And you have to identify which muscle is inserted onto this landmark, right? So, which landmark is this? This is very good. This is actually lesser trochanter, right? And for lesser trochanter, iliopsoas is the muscle which is inserted, right? So this is iliopsoas, very good. And this is flexor of hip joint, right? So iliopsoas, perfect. Now, which set of conditions will shift the curve to left? It means this is oxygen hemoglobin dissociation curve. Now, which condition will shift the curve to left side? Right? And when we say left, it means the oxygen will remain bonded to hemoglobin. What are those conditions? What are those conditions which will shift the curve to left? It means oxygen will remain bonded to the hemoglobin. Yes, everyone is correct. Decrease temperature, decrease 2,3 dpg, to decrease carbon dioxide, and that is what alkalos is actually. So option B, perfect. Yes, yes. Chalo, next question. I think just looking at the image, you can appreciate what problem is here, because the moment the patient tries to do a pushing action, there is prominence of the medial border of the scapula. So this is known as winging of scapula. And I think everyone can identify which nerve is gone. This is very good. So this is long thoracic nerve of Bell. Yes, perfect. So this is winging of scapula, especially on pushing action against, and we usually do it against the wall, right? So this is winging of scapula. Good. Now, what is your diagnosis? Looking at this, this is pulmonary angiography, right? This is pulmonary angiography, and you can see there are slight blockage, right? So here you can see slight blockage. So this is here. So you can see one blockage here. What is this? I think this is classical. Yes, yes, very good. This is classical for pulmonary embolism, right? So this is, that's why we call it gold standard for pulmonary embolism, because we can mark out the embolus. We can just look at the site of embolus, right? So this is a case of pulmonary thromboembolism, and these are all embolus actually. These blockages are actually embolus, right? So pulmonary angiography, we are just studying the vasculature of the pulmonary tissue, right? So embolism, yes. Next question. Now what you can see here, you can see that the placenta is lying low and it is somewhere blocking the cervical os as well. So this is placenta previa, right? So this is placenta previa. Okay, classical placenta previa. Next question. Now, what is this green colored structure? Firstly, you have to identify this, and then you have to identify what is the point of drainage of this green colored structure. So this green colored structure is actually thoracic duct, and thoracic duct is like, suppose if this is left internal jugular vein, this is left subclavian vein, and this is the point of opening of the thoracic duct. This is the thoracic. Okay, so it is the junction of the left internal jugular vein with the left subclavian vein. Clear? So this is, yes, this is thoracic duct, and this is the point of opening. Right? Now again, if you have this kind of histology where you see mononuclear cells, multinucleated giant cells, in a case of bony tumor, the answer has to be, yes, Raghu, you are absolutely right. The answer has to be osteoclastoma, or what is known as giant cell. Right? So this is giant cell tumor. Okay. So I think everyone can identify what is this. This looks like sunflower, though this is Wilson disease. Okay. Now, patient died because of myocardial infarction, and when the heart tissue was biopsied and it was stained, and we saw that the infected portion was white. So the dead portion, it is stained white, right? So here you can see this is all white, and then the normal portion was brick red. So this is all normal. Okay? This part is all normal, and this one is the infarcted area. Now, which stain is this? Which is helping us to, very good. So this is TTC, that is triphenyl tetrazolium chloride. Yes, so I think this everyone can identify. Now, the bacterium which has a safety pin appearance, I think everyone can identify this. This is Yersinia pestis, right? So safety pin appearance. So next question. Again, you can see this whole area of the lung is white. So what is this? It's see, this is consolidation, right? Now, some students I think are confused with pleural effusion. Now, in cases of pleural effusion, you will get an opacity, but that opacity will be, if I draw it with some other color. Suppose if you are drawing pleural effusion, it will be like this, right? So, pleural effusion will be something like this, okay? There is a meniscus, like the upper end is like this, okay? So the upper end is like this, and the pleural effusion is always going from below to up because there is collection of fluid, right? And fluid will always settle at the bottom. Clear? So it will never go, and it will never show you an opacity in the upper part. Clear? fluid has to be always under effect of gravity. It will always come to life here. And the earliest thing which you will notice here is obliteration of the costophrenic recess. So this is normal, something like this. Okay, this is normal. Costophrenic. Costo is ribs, phrenic is diaphragm. So normally you will see like this. But if there is effusion, suppose if I draw it here, this is the normal costophrenic recess, and in cases of effusion, it will be like obliterated. So you will get a picture something like this. So this is known as, this is costophrenic recess, right? So normally this is normal, and this is pleural effusion. Clear? Very good. And this is known as Alice curve. Wonderful. This is Alice. Right? So the curve has to be on towards the upper side, right? And never and never you can have an opacity for pleural effusion which will be seen on the upper lobe of the lung, right? So please, yes, radiological appearance you might confuse, but pleural effusion has to be always in starting from the lower part. So please don't mix up. Pleural effusion will also always be on the lower part, and this is upper lobe consolidation, which is most commonly related to pneumonia. Most commonly. Clear? So this is upper lobe consolidation. Please, don't mix up. Now, what structure is shown with the arrow? This is which cartilage? This is above vocal cord, so it is known as this is above vocal cord, so this is known as epiglottis. Clear? So this is epiglottis. Clear? Epiglottis. Yes, right. Now, which type of joint is shown here? You can see these are the two pubic bones. So this is actually pubic symphysis. Clear? This is pubic symphysis. And pubic symphysis is which kind of joint? Yes, this is secondary cartilaginous. And one thing you can also remember that secondary cartilaginous are usually in the midline, right? So if you see a cartilaginous joint in the midline, if you don't know the answer, it is better you can go for secondary cartilaginous. Clear? So they are usually in the midline. So pubic symphysis is one, intervertebral disc is another example of that. So secondary cartilaginous. Yes, wonderful. Now, in this, there is a clue, multiple draining sinuses on the foot. Whenever you see a case with multiple draining sinuses, there are multiple openings through which there is discharge. So these are all sinuses, and along with that you can see swelling or induration. What is this? This is classical case of Madura foot. Okay, so Madura foot or actinomycosis almost have the same presentation, and you can have multiple draining sinuses. Yes, mycetoma is perfect. Yes, you can write mycetoma. Yes, it's okay. Madura foot or mycetoma. Perfect. I think it's quite easy to identify. Now, this is a transverse section of trachea, and what structure is 4? So, what is this number 4? Now, this number, now if you know that trachea, it contains C-shaped rings. Okay? So, the tracheal rings are something like this. Okay? So, this is a tracheal ring. And posteriorly, we have a muscle, right? Yes, very good. So posteriorly, this ring is completed by a muscle, and this muscle is known as trachealis. Clear? So this is trachealis muscle. And why there is this trachealis muscle? Because posteriorly there is esophagus. Okay? So posteriorly there is esophagus. And whenever we eat food, it might, push the posterior aspect of trachea. So this trachealis actually helps in collapse of the trachea whenever we are eating food. So this is trachealis muscle, right? So this is all trachealis, completing the C of trachea. Very good. Now what is this sign and where we find it. This is carpal spasm, okay, which is also known as tetani. And I think the moment I write this, most of you must be able to answer that this is a typical appearance in a case of hypocalcemia, right? So this is carpal spasm. Okay, so I think no much discussion needed on this. Then a lady was subjected to ultrasonography, and this is what we have. Yes, Trousseau sign, very good. So this is what has been evaluated here. Now, what is this NT? NT is actually knuckle thickness. Yeah, so this is knuckle thickness, and knuckle thickness is like very important. Yes, wonderful, wonderful, Ishan, Shika, good, everyone is right. So this is very important for Down syndrome, right? So what we do while doing the ultrasonography, we measure the knuckle thickness, and any value less than more than 2.5 millimeters is taken as abnormal, right? And along with this, we also look at the nasal bone, right? So we don't take it alone. Nasal bone is also evaluated. If there is absence of nasal bone, then it is more suggestive of Down syndrome, right? So these 2 points, knuckle thickness and nasal bone, on antenatal ultrasound done for Down syndrome. Yeah. Now, the patient has pitting of nails, subungual hyperkeratosis, and oil drop changes. Now, this is suggestive of which condition? So, pitting of nails, you can see here, there is small depressions, right? You can see so many depressions on the nail, right? So this is pitting of nail, there is subungual hyperkeratosis and oil drop changes, and very good. But there is one more thing which has not been mentioned in the question statement, and which I want to show you. Like, just look here. This, if you see, the color of this part is yellow, right? So you can see some part of the nail is appearing yellowish, and this is known as onycholycosis. Okay, this is onycholysis, and that is very suggestive of psoriasis. Although this particular can be seen in trauma or fungal infections, but in settings of oil drop changes, hyperkeratosis, pitting of nails, it goes more in favor of psoriasis. Clear? So this is psoriasis. Now, Congo red stain under polarized light gives you apple green birefringence. I think everyone can answer this. This is a classical amyloid, right? So this is apple green birefringence. Okay, under polarized. So under polarized. Okay, yes, amyloid. Perfect, perfect. Okay, next question. I think you can see there is a capsule, then you can see two bacterium together. So, and importantly, lanceolate shape. Do you have this kind of description? Your answer has to be pneumococcus, that is Streptococcus pneumoniae, right? So, lanceolate, something like this, pointed on both the ends. This is lanceolate, right? So you can see it is pointed here, it is pointed here, and diplococci. So clear? So this is pneumococcus, right? Pneumococcus. Yes, Kuling reaction to demonstrate the capsule of pneumococcus. Very good. Right. So next question. Post-COVID, diabetic, black scar, orbital swelling, proptosis. I think whenever you find these words, you can say that it's a case of mucormycosis. And yes, the mucormycosis, the answer is quite clear. And you can see the branching hyphae. So you can see the hyphae, right? So this is mucormycosis. Okay. So this is mucormycosis. Yes, the history is suggestive of the diagnosis. Even if you don't know the image, that won't make much of a difference. So next question. I think quite clear. You can see the typical spoon-shaped nail. So this is spoon-shaped nails, and that is iron deficiency anemia, right? Yes, yes, Raghu, absolutely right. Now, next question. There is a patient with itching of eyes and excessive lacrimation, and when you turn the eyelid, you saw something like this. So you can see elevations like this. This is known as, yes, this is known as, you can see these elevations. What are these elevations? Ishan, you are correct. This is known as cobblestoning, right? So this is known as cobblestoning, and whenever you find this word cobblestoning, your answer has to be spring catarrh, that is vernal keratoconjunctivitis. Please, clear? This is cobblestoning, right? Okay, VKC, perfect, perfect, Ishan. So next question. I think everyone can easily mark out the appearance on CT scan. This is something like the banana appearance, right? Yes, Ahmed, perfect. So what is this? I think everyone should identify this. This is a typical case of subdural hemorrhage, right? So, appearance, subdural hemorrhage. Yes, right. Now here you can see the large eyes, and that is known as congenital glaucoma or ophthalmos, right? So you can also have sometimes the word congenital glaucoma here, right? So this is congenital glaucoma. Now, what management of this condition? So firstly, you have to identify what condition is this. Now, if you can see, there is so much of crusting, right? So there is so much of crusting, and therefore this condition is known as crusted scabies or Norwegian scabies, right? Clear? Yes, Raghu. So this is crusted scabies or Norwegian scabies, and what happens here? And the important classical feature is that absence of itching, right? And since the patient does not itch, so all the mites, they are present within these crusts, right? So what happens? The mites persist within crusts because they are not dislodged, and therefore what happens? This such a patient is highly infectious, loaded with so many mites, and just because no itching. So what we need to do, we need to give ivermectin plus topical scabicides. So we can give 5% permethrin or PHC along with ivermectin, right? So so this is the option, right? So this is combination of both. Norwegian, yes, absolutely right. So this is Norwegian scabies, right? So next question. Again, you have to look for the displacement of the distal fragment, and this is the distal fragment as such. So, right, and this is the volar aspect, and whenever the distal fragment goes to the volar aspect, this is the proximal fragment. This is proximal, and this is the distal. So if the distal is going volar aspect, you will call it, what is this injury? If the distal fragment of the lower end goes, Ishan, you are perfect. Ishan, you are perfect. So this is Smith's, right? Always remember, we have to talk in terms of the movement of the distal fragment, right? If the distal fragment of lower end radius fracture, right? Just look at the movement. If it is going volarly or it is going dorsally, just check. If it is going volarly, call it Smith's, and if it is going dorsally, call it Pulmonary. Clear? So you have to look for the displacement of the distal fragment, then only you can be right. Otherwise, if you just go for Coley's just looking at the side of fracture, you might be wrong. So just look for the displacement of the distal fracture of the lower end of radius, right? So this is a typical Smith's fracture where the distal fragment is displacing towards the volar side, right? Right. So this is Smith's. So the next question. Patient had fever, headache, knuckle rigidity, and then suggestive of meningitis. And when you did lumbar puncture, CSF examination showed you gram-negative diplococci. Now, what is the answer? So first thing is that patient has meningitis. Second is it is caused by gram-negative diplococci. Clear? So here you have two important clues, and diplococci again means two bacterium together. So what will be your answer here? See, most of you are right that it is Neisseria, but some are saying that it is Neisseria gonorrhea. I'm sorry, it is not Neisseria gonorrhea, it is Neisseria meningitis. See, the answer is there in the question itself. No? Gonorrhea is for gonorrhea, right? That is per urethral discharge. It has nothing to do with meningitis. Clear? So this is not the answer here. This is meningitis, and of course, the picture of meningitis is given here. So there is no point saying gonorrhea. So don't mix up, dear students. This is Neisseria meningitis, and if you look here, this is red. So that is gram-negative, right? And when we have a close look, it appears something like. If you look, it will appear something like this. So diplococci, there are two bacterium which the appearance is something like this. Okay, so this is Neisseria meningitis. Clear? So don't mix up. So this question I think is quite easy. You can clearly say this is a case of acanthosis nigricans. You can see hyperpigmentation in body folds. Okay? So it can be axilla, or it can be nape of neck, right? So this is acanthosis nigricans. Not much to describe. Now, what is this splint? This splint is, yes, Ahmed, everyone is right. Yes, yes. This splint is Dennis Brown splint, right? So this is Dennis Brown splint, and this is used to maintain correction achieved by casting in CTV, right? So this is, yes, I think everyone can answer it. This is used for CTV. Clear? Now, the moment you have this kind of picture post-trauma, I think there should be no confusion in jumping onto the answer, right? This is post-trauma. If you have this kind of picture, I think everyone can answer that this is a case of posterior dislocation of hip. Yeah. So here we are getting a classical faded deformity, right? And the answer is, yes, everyone is right. This is sciatic nerve, right? So here you can see there is flexion, right? There is flexion, there is adduction, and there is internal rotation. Clear? Right? So this is faded deformity, sciatic nerve. Prabhu, absolutely right. Now, what is this condition? I think all of you should answer this. This is quite very basic, and everyone should know this. Right? Just look at the appearance of eye. Yes. Yes, I'm waiting for your answers. Very good. So this is amaurotic cat's eye reflex. Very good. Or leukocoria or white reflex. Clear? So the moment you have this kind of word, retinoblastoma. So no one should make any error in this. Yes, Flexner, Winterstein, Rosette. Now, whenever we are doing lumbar puncture, right? So this is lumbar puncture, or you say giving spinal anesthesia. There is no penetration for intervertebral discs, right? So we do puncture supraspinous, interspinous, or ligamentum flavum, but not intervertebral disc space, right? So while doing lumbar puncture or giving spinal anesthesia. So I think please remember this, right? So like if these are vertebral bodies, in between the vertebral bodies we have the intervertebral disc. So this is the disc, and the spinal cord is here. This is the spinal cord. Right, and then we have this is the subarachnoid space, right? So this is, you say, dura mater, arachnoid, right? So what we are doing, we are actually going up to this place, right? So this is the needle. So we are reaching up to the intervertebral disc space. Clear? So this is how you should remember. So this is an organism which is causing diarrhea. Now, what is this? Can you identify what is this? This is showing falling leaf motility. What is this organism? Falling leaf motility and causing diarrhea. Yes, perfect. Everyone is perfect. This is Giardia lamblia, right? So this is Giardia lamblia. Yes, good, right? So then number one is thyroid. This is thyroid cartilage. This is cricoid cartilage, and this is thyroid bone. Yeah, so no much discussion for this answer. This question, thyroid cartilage. Now, a patient has hypopigmented macules and KOH showed spaghetti and meatball appearance. Yes, Raghu, yes. So, hypopigmented macules, right? Which may coalesce to form larger hypopigmented patches. And this is, yes, this the classical, this is triasis versicolor. Yeah. And this is Malassezia furfur. Yes, everyone is right. And moreover, you have this classical finding of spaghetti and meatball. So you may have something like this, and then you may have rod like. So this is spaghetti and meatball, or banana and grapes. Clear? Yes, this is Malassezia furfur. So next question. I think this is quite easy to answer. You can see envelope here, core particle here. So related to envelope antigen or core antigen, you can easily answer it as a case of hepatitis B virus. Clear? And of course, you can see it is a DNA virus. It is a DNA virus. Clear? So this is hepatitis B virus. Then this is very easy to identify. You can see this is polyvinyl chloride endotracheal tube. Right? So this is endocranial tube. Now, what is this condition shown? What is this? Well circumscribed patchy hair loss. Yes, what is this? Wonderful. This is alopecia areata, right? So this is alopecia areata. Very good, very good. And what you see here, exclamation mark here. Okay? So the hairs are wider above, narrow below, and this is the hair follicles, right? So this is exclamation mark here. Good. So now this is, I think, weeds are grasped in hand. This is instantaneous rigor, which is also known as cadaveric spasm. Yes, so this is instantaneous rigor or cadaveric spasm. Okay. So now here we are seeing a fungus which is having hyphae with acute angle branching and septations. Now what is this? Yes, so here we can see acute angle branching and septations. Right? So here you can see septations. These are actually septations, right? So you can see the septations here, and there is acute angle branching, means the angle of branching is less than 90 degree. This less than 90 degree angle of branching. So what is this? Very good. So this is aspergillus. Okay. This is aspergillus fungus. Yes, yes, very good. Now, if there is, this is mummified, in fact, even right. Cases of mummification, we don't find any odor as such. So there is no odor. Okay. I think everyone can identify this is the typical Casal's necklace. Yeah, so this is Casal's necklace, and I think everyone can correlate it with deficiency of niacin, and the condition, of course, is palliculum. Okay, so yes, sure. Now this is important. This question is important. What condition is shown in the image? There is slight description also, like early fungating cauliflower plaque-like. So what is this? Kapil, yes, you are right. This is condyloma acuminata. Raghu's, you are wrong, slightly wrong here. Now, these are two. Actually, many times students are really confused between these two conditions. So let me. So these are two different conditions. See, condyloma lacuminata, this is secondary syphilis. Clear? So this is bacterial, but this is viral, human papilloma virus 6 or 11. Clear? So this is one thing. Now, what appearance you have to see so as to identify whether it is condyloma lata or condyloma acuminata. Now, condyloma lata, they are actually moist patches, right? So these are actually moist lesions, right? And acuminata means spines, you can say. So these are, you can see pointed eruptions, or sometimes you can see cauliflower-like lesions, right? So this, sometimes the lesions may be like this, something like this. Okay, so this is condyloma acuminata, and condyloma lata are simply moist lesions, right? Yes, and that's slightly confusing on the part of the student because the words are somewhat similar and they often mix up. So the moment you find this word cauliflower, think of condyloma acuminata, right? So just make sure that you don't mix up, right? So this is condyloma acuminata. Okay, yes, Kapil, you are right. So just for this particular thing, I kept this image because yes, it's slightly confusing on the part of students. Now just look at the appearance of the, this is affected eye, this is normal eye, and what you can see in the affected eye as compared to the normal eye. Now see here, one thing you can easily see here, that the upper eyelid is drooping down. Okay, so the upper eyelid is drooping down, and that will be known, that is known as, yes, you can see upper eye is drooping down. So one thing is ptosis, and secondly, you can see, look at the pupil. Pupil is dilated, so that is mydriasis. And third, just look at the division of eye, downward, outward. So downward and outward deviations. These are the 3 points which you can find here. Now, ptosis is because of paralysis of levator palpebrae superioris, which is supplied by which nerve? Third nerve, right? Mydriasis, this is because of paralysis of sphincter pupillae, right? And this is again supplied by third nerve. Downward and outward, actually, sorry. Downward and outward, this is because of overactivity of the superior oblique muscle, right? So which abducts and depresses the eye. So this is because of overactivity of superior oblique, and we know that superior oblique is supplied by trochlear nerve. Clear? So this suggests that there is paralysis of third nerve. Clear? Yes. So please remember, like there are 3 clues in this question. Even if you know one, you can straightforward you can mark. And moreover, ptosis is one of the important clue here, because levator palpebrae superioris is paralyzed, which is supplied by oculomotor nerve, right? So there are 3 clues, and you can easily get up to the answer. Yes, LR is also spared. Yes, LR is also spared. So yes, you can write it. Lateral or outward because of LR, which is supplied by 6th abducens, right? This is 6th. Yes, you can write that. Clear? So that is classical for oculomotor nerve paralysis. Fine. So next question, I think it doesn't need any discussion at all. This is elephantiasis, which is also known as filariasis. Everyone can identify this. So, next question. Now here, a truck driver have firstly painless ulcer over genitals, for which he didn't took any treatment. Now he's having the presentation something like this, and this is actually symmetrical rashes, right? And this was primary syphilis, and now the patient has gone into secondary syphilis. Clear? So the answer is secondary syphilis, right? So symmetrical rashes, and you can see the rashes are present in both the hands, right? So these are all rashes. Clear? So secondary syphilis, very good run. So next question, I think we have already done this, but again we can take what is shown by the yellow arrow here, or if I draw it, I am asking about this. What is this structure? What is this structure? Yes, everyone is right. This is putamen. This is caudate nucleus. Okay, this is putamen, and here will be thalamus. Clear? So, and this is how you can remember, right? Okay. So this is the answer is putamen. Okay. And if putamen is not there, lenticular nucleus can also be the answer, which is actually putamen plus globus pallidus. Okay. Yes, Raghu, you are absolutely right. Now look at the X-ray. What you see here in the X-ray, you can see something lines like this. So lines at the base of lung fields. Base of lung fields. I think everyone can answer this. What is this? Lines at the base of lung fields. Very good, very good, very good, Dr. AM. Yes, this is curly B lines. That's why I was focusing more on the word B. So this is curly B lines, and curly B lines are seen in pulmonary edema. Okay? So don't forget, this is curly B lines of pulmonary edema. You will see straight line at the base of lung fields. Ciao. Next question. I think this is quite obvious. You can see this is typical leonine facies, right? So lepromatous leprosy. Okay, so this is lepromatous leprosy, right? And now non-sporing bacteria. If you look at the appearance here, this is known as Chinese letter arrangement. So I think everyone can answer is, what's this? Very good. So this is Corynebacterium diphtheria, right? And you can see these are metachromatic granules, which are also known as Bulletin or Babes Ernst granules, right? So this is Corynebacterium diphtheria, right? Now I think a child with inspiratory stridor and epiglottis, assuming the omega shape. So this is omega shaped epiglottis. The answer is quite obvious that it is a case of laryngomalacia, right? So this is an omega shaped epiglottis, and the answer is laryngomalacia. Clear? Yes, absolutely. Raj, Ishan, yes, AM, all right, all right. So this is laryngomalacia. Please don't do any sort of error in this question. It is very easy and very favorite also. Now, there is injury to the visual pathway, and this is what is seen. So what is your diagnosis here? Which part of the visual pathway is injured? Which part of the... Yes, very good. This is optic chiasma. Very good. So you can see here, if I draw it like this, right? If I draw it like this is the nasal part. Okay. So on the nasal part, both sides the patient can see, but on the temporal part, this is temporal, or temporal is also known as lateral. Okay. So this is lateral, this is medial, half of the visual field. So you can see on temporal side there is no vision, right? No vision. There is no vision here. So therefore this is known as by, means both side, temporal means lateral half of the visual fields, hemi means half, anopia means no vision, right? So this is bitemporal hemianopia. Yes, optic chiasma, or because of tumors of the pituitary gland, especially pituitary adenoma, which compresses the optic chiasma, right? So this is bitemporal hemianopia. Clear? So this is how it sees. I think this is a very basic question. Everyone can answer this. This is rhinophyma, which is the hypertrophy of the sebaceous gland of the nose. So this is rhinophyma. Clear? I think everyone can answer this. Not much for discussion in here. Clear? This is rhinophyma. Now, next question. India ink staining, and you have this kind of appearance. I feel everyone can answer this. This is cryptococcus, right? Again, I am telling you, like, cryptosporidium is HIV plus diarrhea, and cryptococcus is HIV plus meningitis. So please don't mix up, because both the words, they start from the same alphabets, that is crypto. So at times it student they just mix up, right? So cryptococcus, not cryptosporidium. Please correct. It is cryptococcus, right? So this is India ink preparation, especially in a setting of meningitis, right? So this is cryptococcus. Please correct. Now I think the moment you see this kind of gametocytes, the banana shaped gametocytes, right? This is Plasmodium falciparum. Okay, this is Plasmodium falciparum. Okay? Chalo, next question. Here you can classically see low posterior hairline, then webbing of neck and shield chest. Three clues are sufficient to make a diagnosis of Turner syndrome. Clear? So this is very important here. Turner syndrome. Now, which tendon is this? Which tendon is this? Yes, everyone is right. It is Turner syndrome, right? Yes, this is extensor pollicis longus. Very good. This is extensor pollicis longus. And when we say extensor pollicis longus, this is which boundary of anatomical snuff box? Anatomical snuff box. This is lateral boundary. Please remember, many students they mix up. Then this is medial boundary. Sorry, I myself mixed up. So this is medial boundary, right? Yeah. So medial boundary of anatomical snuff box, and right. So you have this tendon over here, and then you have two more tendons going something like this. So this is extensor pollicis longus. Here we have extensor pollicis brevis plus adductor pollicis longus. Okay. So this is the medial border of the anatomical snuff box. Yes. Okay. So please remember like this because it is towards the little finger. This is medial. Clear? So this is extensor pollicis longus. And these two are towards the thumb. So these are lateral. Yeah, these are lateral. Fine. Sure. Great. Now, what you can see here, this is the lung field, and you can see a small hump-like thing. What is this? Again, I want to correct you. See, if there is pleural effusion, you will have a opacity, but it will be like something like this, right? So the concavity is like here, but what you can see, the concavity is downwards. Yes, correct, right? So can you make the difference? If the opacity is like this, you will call it pleural effusion, right? This is pleural effusion. And if it is like this, you will call it Hampton's hump, right? So this is Hampton's hump. And the moment you find the word Hampton's hump, your answer has to be pulmonary embolism. Clear? So this is Hampton's hump, pulmonary embolism, and pleural effusion, concavity should be upward. And that what is Ali's curve, no? This is Ali's curve. Clear? So please remember like this. So please, okay, Raghu, I'm sure you will note this, right? Then a child with hemarthrosis after fall. This is a classical case of hemophilia, right? So especially affecting the knee in males. Right? So this is factor 8 deficiency. Okay, so this is factor 8 deficiency. The next question here you can see peristalsis. Okay, this is classical peristalsis. There is constriction at one place and relaxation at the distal place, right? So this is distal and this is proximal. Okay, so proximal constriction, distal relaxation, so that the foot it moves forward. This is peristalsis. Clear? Yes, this is peristalsis. Proximal constriction, distal relaxation. Now, what you can see here, just look at the image, and I think I have given you two set of images. Even if you know one, you can easily answer. So here you can see that this is banana shaped gametocytes. Right? So this is banana shaped gametocyte. I think this will help you, but I want to focus you on the other image as well. So this is banana shaped gametocytes, and what you are seeing in the first image, yes, what you are seeing in the first image, if you look properly, these are the trophozoites, and the appearance is somewhat like headphones, right? So one here, and this is known as headphone appearance, right? This is classical. Clear? So this is known as headphone appearance, and the moment you have headphone appearance kind of trophozoites. Yes, very good. So this is Plasmodium falciparum. Although this one was quite obvious, but I just want to make you know this one also. So headphone, banana shape, think of, yes, right. So this is Plasmodium falciparum. Clear? Now what is this? You are seeing a breast tissue and you can see something has been implanted. What is this? Breast. Yes, Ishan, perfect. Anyone? Wonderful. This is radiotherapy for breast carcinoma, and that is interstitial brachytherapy. So the source of radiation is implanted within the tissue itself, and that is interstitial brachytherapy, right? So this is for breast tumor, right? So this is how we put the source of radiation. Here it is within the tissue, or brachytherapy means the source is closer to the tumor. So that is brachytherapy. Yes, wonderful. Now water is maximally reabsorbed here. So in this region, and this is proximal convoluted tubule. This proximal tubule. Clear? So this is PCT. Now this is Suraksha Clinic for sexually transmitted diseases. Okay. In terms of kidney, we are talking in terms of kidney. So that is PCT. Yes, wonderful. So this is Suraksha Clinic logo for STDs. Right? Nothing much to discuss here. Now here you can see that there is same kind of waves. So this is monomorphic. Clear? So this is monomorphic ventricular tachycardia. So this is monomorphic ventricular tachycardia. Okay? So same kind of waves up and down. So monomorphic ventricular tachycardia. Now look at this image here. What you can see. Obviously, this is a type of cataract. What you can see here, classical picture. Yes, yes, very good, very good. So this is snowflake cataract, or what do you call diabetic cataract? And this is because of accumulation of sorbitol. Yes, everyone is right. Now, this condition is duodenal atresia, annular pancreas, and there is a rim of pancreatic tissue which is surrounding the second part of duodenum, right? So this is duodenal rim, and this is there is a rim of pancreatic tissue which is surrounding the. This is the pancreatic tissue. Clear? This is pancreatic tissue, and it is surrounding the second part of. Clear? So this is annular pancreas. Okay. So the pancreas is surrounding the second part of duodenum, and it is having a constricting effect. So if you see, this is the pancreatic tissue which is encircling the second part of duodenum, right? So this is annular pancreas. Now let us move to next question. There is gradual onset of backache with morning stiffness, and there is redness in the eyes as well. This is X-ray. What is your diagnosis? I think this is a very classical X-ray, and most of you can easily make a diagnosis here. Either you can go with the history or you can look at the image. The diagnosis will be pretty clear to you. Yes, very good. So there is early morning stiffness. This is very important, and this resolves with activity. This is actually acute anterior uveitis, and classically you can see on X-ray the clear. So yes, this is, I think everyone can answer. This is ankylosing spondylitis. Now here, this S1, this all period is actually systole. Closure of AV valve to the closure of semilunar valve is systole, and therefore any murmur within that period is known as the systolic murmur. And here, the murmur which is shown is the ejection systolic murmur, which increases intensity during the systole, and later on, as the systole wanes off, it also decreases in intensity. So this is ejection systolic murmur. Varies according to the force of systole. Yes, Raj, you are right. Shubham, everyone is right. Yes, crescendo, decrescendo. Yes, this is known as crescendo, decrescendo. Wonderful. So this is ejection systolic murmur. In short, you can write yes. Now, what is this bone? Just identify this bone. Of course, this is middle ear ossicle. Which bone is this? Now, this is actually a neat PG question and really very confusing, but this is incus. Okay, so this is not malleus, this is incus, right? So this is incus, not malleus, right? So this is incus. So here we can see the image. This is the malleus, and this is the incus, and of course, stapes is quite easy to identify, right? So this is the incus. Clear? So I think just make sure that you don't mix up now. So this is incus, right? Chalo. Now what is this ECG? You can see sawtooth P waves. What is this? Sawtooth P waves. Very good. This is atrial flutter. Very good. Very good. Now, a patient has mild hearing loss with nasal obstruction. This is so hearing loss with nasal obstruction, and when we did a otoscopic examination, we saw this kind of picture. Yes, anyone? Very good, Ishan. Very good. So you can see there is right. So right here, yes. So here, the moment you have this word air bubble appearance, right, or fluid air appearance, this is serous otitis media, and this nasal obstruction is because of what is the reason for this nasal obstruction? This is because of adenoid hypertrophy. Yeah, that's why in a case of adenoid hypertrophy, always do a otoscopic examination for serous otitis media, that is otitis media with diffusion, which is also known as glue here. Clear? So very classical case, and just look for air fluid, yes, effusion within the middle ear. Now what is this? You can see multiple purple linings, or this is known as purple striae. What is this? Classically seen in Cushing syndrome. Very good. So this is Cushing syndrome. Okay. Chalo. Now, let's move on to next question. A woodworker, there is localized lesions over the leg and which are irregular and cauliflower-like. And when we did histopathology, we found copper penny. The moment you find the word copper penny, the answer has to be yes, perfect, perfect. This is chromoblastomycosis, right? So you can see the copper colored bodies which are right. So this is copper penny, cauliflower lesions, especially related to someone if like working with in forest or in garden. So these are the typical for chromoblastomycosis, and the lesions are typically cauliflower like. Yes, so chromoblastomycosis. I think everyone can answer this. This is clubbing. So this is classical clubbing. So not much of discussion for this. This is clubbing. Now, what is the management of this fracture? If you see, this is first metacarpal, right? This area is base, and here you can see that this is the fracture line. So this is the fracture line. So this is actually when it's fracture involves the, which is also known as the intra-articular fracture base of first metacarpal, and this should be managed by or better is ORIF. Clear? So better is ORIF here because it is an intra-articular, right? So intra-articular, it needs fixation under vision. So it's better you go for ORIF. If that is not in the option, then you can go for close reduction internal fixation, right? But better you go for, yes. If ORIF is there, definitely go for ORIF. If ORIF is not in the option, as in case of this MCQ, we can go for close reduction with K-bar. But ORIF has to be done, especially in intra-articular fractures. Please remember, this is always the priority for intra-articular fractures, right? Sure. Now what you can see here, there is very steep Y wave, and this is constrictive pericarditis, right? So steep by descent. And in cases of cardiac tamponade, it is absent by descent, right? So please remember, absent by descent. So this is how we differentiate the two conditions on JVP. Clear? So please remember, steep is constrictive pericarditis. Please correct yourself. Yes, right. So now this is an X-ray, and you can see there is thorax. So this is pneumothorax. Pneumo, I think everyone knows this is air. So whenever there is collection of air, you need to do emergency. You need to pass a needle. So that is known as needle thoracostomy. So left-sided needle thoracostomy, and this seems to be a case of tension pneumothorax. Yes, so you have to pass it in second intercostal space, right? Because air has a tendency to move upward, so go through the second intercostal space. Clear? So this is for tension pneumothorax. You can see collapse of lung as well. Lung collapse can also be seen in a case of tension pneumothorax. Yes, Shubham, right. I think the classical color changes from pale cyanosed to rigor. This is Raynaud's phenomenon. So NPC, clear? So this is Raynaud's phenomenon. Now this is an structure which was found 2 feet proximal to ileocecal valve, and I think if you know the rule of 2, this is nothing except Meckel's diverticulum, right? So this is Meckel's diverticulum from the antemesenteric border of the terminal ileum, and just 2 feet proximal to the ileocecal valve. Yes, from the antemesenteric border, opposite to the border where the mesentery is attached. Clear? Sure. Then what you see in this audiogram, you can see this is the value 2000 hertz, and here you can see a dip. So there is a dip at 2000 hertz. Now what you will call this, there is a dip in the audiogram at 2000 hertz. Dip, right? So this is known as Carhart's notch. Very good. This is related to otosclerosis. Okay. So Carhart's notch. Yes, right. Now the moment you have this kind of picture, I think you can see that the index finger is extended, whereas other fingers can be flexed. So whenever you have this kind of picture, you can say it's a case of, it's an image of pointing index. This is pointing index, and I think most of you might say that this is because of median nerve paralysis, right? So this image is because this is prayer sign. If you see here, this is prayer sign, and that has to be related to diabetes mellitus. So this is diabetes mellitus, right? The next African patient after surgery, some skin problem, always think of keloid, and here the keloid, suppose if this is the original limit of, suppose if this is the original limit of the scar, the keloid, it has a tendency to extend into the normal skin. So this is keloid. This is the scar area, and this is all the extension of keloid. Okay? So it extends into the normal skin. Yes, keloid. Now, next question. A female has pruritus, that is itching with white curgy discharge, and on microscopy we can see budding yeast cell with pseudo hyphae. What is used to identify the causative organism, right? So if you can just look at with this much clues, you can easily make a diagnosis. Like there is itching, right? Then there is white curdy discharge. Now this curdy word is very important here. So white curdy discharge, and then microscopy, you can see a fungal reason. Yes, this is candidiasis. Very good. So this is the diagnosis is candidiasis, vaginal candidiasis. Now what you need to do to identify the organism. Option A, B, C, D. What? Classical white curdy discharge. What do you need to do? SDA, right? So this is Seborrheic dextrose agar. Clear? So this is a classical fungal infection, and we can grow it on SDA, that is Seborrheic dextrose agar. So this is very important here. And itching is always more than the amount of discharge. Prurite is always more in comparison to the amount of discharge. Right? That is vaginal candidiasis. Now here you can see we can pass a probe. This is one opening, this is another opening. We can pass a probe, and this is fistuline N, right? So this is fistuline N. Clear? And with the serous discharge per N. So this is fistuline N. Now here you can see this is outer is chorion, the inner one is amnion, and this is placenta. So both the fetus, they have their own amnion and chorion. So this is dichorionic, diamniotic, and seen somewhere between 3 to 5 days of fertilization. So this is diamniotic, dichorionic. Yes. Now this is an copper T, and for IUCD, one of the complication is PID, right? So PID is the complication here. This is PID. ब्रेक ले ले क्या 2 मिनट आ जाओ फिर सीन में बोल तो दो बच्चों को बेचारे को
अरे इनको
बोला नहीं यार बेचारे या मैं यहाँ लिख दूं
यार 2 मिनट का ब्रेक है
मैं लिख दूं यहाँ पे
दिए हम माइक, अब आप गीला संभालिए अपना।
Okay, dear students, we can start the session, right? So now, what is the condition here? Right. So if you look at this condition here, you can see a level which is actually suggesting the level of fluid. Right. So this is the. So the moment you have this kind of picture, I think it is very easy for you to diagnose it as a case of otitis media with infusion. Again, I think all of you must be knowing blue ear or serous otitis media, right? So just look at for this particular presentation, fluid in the middle ear. Now, this is one more question which I want to discuss with all of you, and let me see how many of you can answer it correctly. This is an APN lateral view of forearm, and you can see injury, and let me see what's your answer here. Now, before answering this question, you have to point out three things, right? Number one, which bone is fractured, right? Number two, site of fracture, and number three, what is the nearest radioulnar joint in relation to that fracture. So if you look here, which bone is fractured here? Just tell me which bone is fractured here. You can see this is the fracture site. Yes, tell me which bone is fractured. If we can go step by step, we will definitely reach up to the perfect answer, and that will help you in exam as well. So which bone is fractured here? Very good, very good. So the bone fractured is radius. Now what is the site? This. So one thing is clear, that there is fracture of the radius. This is clear. Now what is the site? The site is lower third, right? So this is lower third. Clear? Because we know that this is the area of wrist joint, right? This is wrist. Radius, lower third, and look at the radioulnar joint. So if you can see here, this is the lower end of ulna. Clear? So you can see that, and this is the lower end of radius. So you can see that there is disruption. Again, this is the lower end of radius, this is the lower end of ulna, and you can see that there is disruption of the, or the, what you say, dislocation of the lower end of lower radioulnar joint. So this is dislocation. Clear? This is the dislocation here. So there is dislocation of the lower or inferior or distal radioulnar joint. Clear? So the moment you have these kind of words, then I think it is very easy for you to make the diagnosis that this is a case of Galeazzi fracture dislocation. Clear? So this is Galeazzi fracture dislocation, right? Now please don't make any mistake in this particular question. Radius, lower third, inferior radioulnar joint dislocation, Galeazzi. And for Monteggia, this is ulna, which is fractured, and there is proximal radioulnar joint dislocation. Clear? So I hope all of you can identify ulna and radius on the X-ray, and just look at the fracture and look at the nearest radioulnar joint. You will be never wrong in your answer. Clear? So this is a classical case of Galeazzi fracture dislocation. Now the number 2, I think most of you can say that this number 2 is optic chiasma, and we have already discussed that if there is lesion at the optic chiasma, we will find the patient having bitemporal hemianopia. Clear? So this is optic chiasma, and not to go in further details of optic chiasma, we will move further. Now what is this organism which is showing this kind of growth? Now this kind of growth is known as swarming motility or swarming growth, and I think most of you can answer which bacterium actually has this swarming growth. Any idea? You can see this is all swarming growth. Very good. This is Proteus, right? So please remember, very good, Raghu. This is Proteus. I think this is Chalesian clamp, and this is used for Chalesian surgery, right? So just look at this Chalesian clamp. Clear? So this is Chalesian clamp. Now again, if you have this kind of picture where you can see Homer-Wright rosettes or Flexner-Wintersteiner rosettes, I think most of you can answer it correctly that this is a case of, we have already discussed a little bit about this, and this rosette word is actually related to, flower kind of appearance. Like, so here you can see this is rosette, something like a flower. Okay, right? So this is, yes, retinoblastoma. So please remember, this is retinoblastoma, Homer-Wright or Flexner-Wintersteiner rosettes. Clear? So this is retinoblastoma, right? I think here you can see that there is process, there is meiosis. Now this is very important here. This is, just look at the size of the pupil as compared to the normal side. So this is normal, this is affected. So on the affected side, you can see that the pupillary size is small. This is meiosis. Clear? And the eyeball appears sunken. Sunken eyeball, that is in ophthalmos. Clear? Very good. So this is Horner syndrome, right? So this is Horner's syndrome. Clear? And this ptosis is because of paralysis of Mueller's muscle. Because we discussed levator palpebris superioris in case of oculomotor palsy, this Mueller's muscle can also, paralysis can also lead to ptosis, right? Now, if you look at the classical hair change, you can see this is black area, this is white area, again this is black area, then white area, right here this is white. So this is the classical flag sign, right? So this is the classical flag sign, and I think most of you must remember that where we see the classical flag sign, right? So this is the flag sign of Vascular. Okay, so many of you might have heard about flag sign, but this is how it actually looks, right? Now, next question. This is a very good question. If you look at the culture plate, you will see colonies which looks like fried egg, right? So this is, you can see this is the extent, right? So this is the fried egg colonies, right? So the moment you hear the word fried egg colonies, the answer has to be yes. What is the answer for this fried egg colonies? Classical. You can see this is the fried egg colonies. Very classical. This is for yes, fried egg. This is classical for anyone. Mycoplasma. Yes. So this is mycoplasma. Okay. Fried egg colonies. Please remember. Chalo, next question. This is a classical, you can see pterygium advancing onto the pupillary margin, and this is the degeneration of conjunctiva, right? So this is classical pterygium, right? Now, what is this? If you can look here, especially in boxers or wrestlers, we see this kind of appearance of the external ear, and that is because of hematoma, and this is known as cauliflower ear, right? So this is hematoma of the auricle, right? So this is because of blunt injury. So this is cauliflower ear. Okay. So next question. There is excess of copper, so there is formation of a ring in the cornea, and this is known as the condition is Wilson disease. I think everyone can answer this. This ring is known as Kesher-Fleischer ring. So need no much discussion as such. So this is Kesher-Fleischer ring, right? So next question. Again, I think we have already discussed it in some other way. So there is a child with fatigue, lethargy, and he is anemic, having enlargement of the liver and spleen. And then we have this kind of peripheral blood smear. And this is, again, you can see the classical target cells, right? So these are the classical target cells. And the moment you find these target cells in the settings of anemia, your answer has to be thalassemia. Clear? So again, we have already discussed this previously. Yeah, this is thalassemia, right? Now, what is this gram-positive organism, gram-positive bacteria, and this kind of appearance? What is this? So this is yes, right. This is streptococcus. Very good. And in staphylococcus, we will have this grape-like appearance. Right? This is staphylococcus, grape-like appearance. Yeah. So this is chain. Yes. So this is streptococcus. Fine. Good. Now here we can see teardrop cells. Right. So these are classical teardrop cells, and these teardrop cells are very suggestive of. Right. So these are teardrop cells. The moment you have this thing, the answer has to be myelofibrosis. So teardrop cells. So what we can see here in this image, we can see vesicles in the external ear. Okay, so we can see the vesicles, and along with it, we can also see facial nerve. See, okay, you can see that the patient is not able to close the eyes completely as compared to the normal side. So this is the normal side, and right there is, if you can look at the angle of the mouth, here it is on the lower side, it has upper on the yes, very good. So on the normal side, it is at a higher level. On the affected side, it is at a lower level. So this is a typical case of Ramsay-Hunt syndrome. Wonderful. So I think all of you can answer this. Now look here, a patient, elderly patient with anemia, gum bleeding, and raised WBC count, and the blood smear is showing multiple OR rods. So these are OR rods. And the moment you have this kind of presentation of oil rods, I think you can straight away go to make a diagnosis of AML, right? So this is AML, right? Now this is again, you can see grouped vesicles along dermatome. So this is classical presentation for herpes zoster. Clear? So this is herpes zoster, and you need to give antiviral, that is well isoclovir or acyclovir. So this is unilateral on one side only. Clear? So this is well isoclovir or the antiviral. Now here you can see a tumor which is arising from femur. This is known as exostosis or osteochondroma, and here we have a cartilaginous cap as well. So there is a cartilaginous cap also, which is not visualized on X-ray, right? So this is the cartilaginous cap, and this is osteochondroma. Okay, nothing much to discuss here. Now, can you identify this bacterium which looks like a Chinese, which is having a Chinese letter arrangement? So Chinese letter arrangement, and I think all of you can answer it as Corynebacterium diphtheria. Okay, this is again a repetition of what we have already discussed. This is radius, and this is the fracture, and here you can see that there is inferior radioulnar joint dislocation, right? This is inferior radioulnar joint dislocation, and therefore your answer will come out to be Cagliese fracture dislocation, right? So just make sure that you don't do any sort of mistake in this particular question. Then a patient with accident has hypovolemia, and we need to give quick quick resuscitation. So we will use a cannula which is having a wide bore, and that is the 14G cannula, right? So this is wide bore cannula, or you mean the diameter is more, so we can give more fluid quickly for quick resuscitation, right? So this is orange color, right? So this is the orange, yes, right. Then next question, there is a patient with hearing loss, earache, delayed speech, and then we can see this otoscopic examination, and here you can see typical air bubbles, right? So the moment you have this kind of picture, this is typical serous otitis media, okay? So this is serious otitis media. So fluid levels, you can see levels in ear, middle ear, right? Now here we can see that there is fusion of the lower end of kidneys. So fused lower poles of kidney, and usually this happens in front of L4 vertebra, and this is horseshoe kidney. Okay, so this is horseshoe kidney. Yes, right. Then next question, we can see this is radio ulnar intraosseous membrane, right? And this is actually syndesmosis. Okay, so this is syndesmosis. Okay, this is syndesmosis. Chalo, next question. Here we can see a patient who is having breathlessness and edema over the lower limbs, especially feet. And on X-ray, we can see that the size of the heart has increased so much, and this is known as the flask-shaped heart, suggestive of pericardial effusion, right? So this is flask-shaped heart. So there is pericardial effusion. So collection around the heart in the pericardial sac. Okay. Now next question. Just a 2 minutes break. Some problem with the setting. I'll get back to you shortly, right? Just a 2 minutes break. Okay. So sorry for that uncalled disruption. We can start the session now, right? So again, we have a USG, and again you can see snowstorm appearance, right? So this is again the typical snowstorm appearance. The moment you have this kind of picture, you can say that it's a case of molar pregnancy, right? So this is hereditiform mole or molar pregnancy. Okay, chalo, next move ahead. Now, which vaccine can be given by this route? So here you can see that the injection is just, this is actually dermis, this is epidermis, right? And below this is the dermis, right? This is dermis. So what we are doing, actually we are injecting the drug in the epidermis. So this is known as intraepidermal injection, and this route is employed for BCG, right? This is intradermal injection, you can say, right? So this is for BCG, right? Rest all other vaccines, they have intramuscular route. So this is intradermal injection. Clear? Now next question. This, look at the CT scan, and you can see that the posterior wall of the maxillary sinus, it has been pushed forward, right? So the posterior wall of the maxillary sinus, it has been pushed forward. This is normal side, and this is the affected side, and this is known as the Holman-Miller sign. And I think most of you must be knowing that it is classical for nasopharyngeal angiofibroma. So this is Holman-Miller sign pushing the posterior wall of the maxilla forward, right? So this is juvenile nasopharyngeal angiofibroma. So next question. Now here you can see that there is a case of tuberculosis, and he had a swelling in the right loin. And in relation to tuberculosis, there is one concept of cold abscess, which can follow the passage of least resistance, and it can present at some distant location. Here we can see that it is presenting within the psoas muscle sheath. So this is known as psoas abscess, right? So the cold abscess, it has moved within the sheath of the psoas major muscle. So this is psoas abscess, or in fact it is a cold abscess in cases of tuberculosis of spine, right? I think everyone can answer this, particularly in the case of obese, hypertensive women. If you see this kind of USG in relation to ovary, this is known as polycystic ovarian syndrome. So again, so you can see the classical necklace appearance, right? So this is necklace appearance, right? Now look at the X-ray here in a child, especially if you see any X-ray of the wrist in a child which shows cupping and splaying of metaphysis, straightforward your answer should be rickets, right? So you can see cupping and splaying of metaphysis. This is rickets. Now what is this? What is this instrument? This is actually autoclave. Clear? So this is autoclave, and autoclave works on the principle of steam under pressure. Clear? So what will be your answer? Your answer will be moist heat. So this is autoclave, right? So the next question. In this question, you can see there are multiple air bubbles within the thoracic field, and this is all actually the loops of intestine, and therefore this condition is congenital diaphragmatic hernia. So these are all loops of intestine. So congenital diaphragmatic hernia, right? So next question. Here you can see that there is narrowing of pylorus. So this is pyloric narrowing, and you can see this is all stomach. So this is infantile hypertrophic pyloric stenosis. Especially the age is very important here. So, and secondly, there is non-bilious vomiting. It means the obstruction is somewhere below the above the opening of above the opening of common bile duct in the second part of duodenum, right? So this is classical age, presentation, and barium picture, right? So this is infantile hypertrophic pyloric stenosis. Nowadays, it is not known as congenital because it is not present at birth. It takes around a month time to manifest. Here you can see there are two gas shadows. One is in stomach, right? So this is stomach, and this is duodenum, right? So especially in the first part. So this is double bubble sign, very suggestive of duodenal atresia, and also in annular pancreas. So either of the two conditions, you have a double bubble sign. Clear? So this is double bubble sign. So we have two air shadows, one in stomach, another in first part of duodenum. Then here we can see if we are drawing, we are drawing a line across the neck of the femur upper part, and if we just draw the outline of the femoral capital epiphysis, the line should pass through the femoral capital epiphysis, right? So capital means head. So this is head. So we are just looking at this line, and in normal child, this should cross through the, or this should pass through the substance of the femoral capital epiphysis. But on the affected side, if you see, it is not going through the substance of the femoral capital epiphysis. It is passing above that. So it means that there is downward displacement of the femoral head epiphysis, and that is known as slip capital femoral epiphysis, right? And this is the classical Trethovan sign. This is what Trethovan sign is, right? So SCFE, in short, you can remember SCFE. Clear? Slipped capital femoral epiphysis. It has slipped downward. Very good, Raghu. Now, identify the organism which shows medusa head appearance. And here it is very easy to identify. In fact, the organism is something like this, and there is a spore in the center, right? So this is the spore, and then if you look at the shape, it is either, you can say, brick or box shape. So this is Bacillus anthracis. Clear? So this is Bacillus anthracis, right? Very classical. Now look at this study over here. We have two groups. This is one, this is two, and in one group we have kept the patients, and in another group we are keeping the normal population, right? So this is case, this is control, and then we are going into past. We are taking history, and then on the basis of that we are looking for that particular exposure to draw conclusion. So this is a classical case of, yes, this is classical description of case control study, right? So this is how we go backward in, this is known as retrospective. So we are taking the histories of that particular exposure. Clear? So this is case control study. Yeah, right. Now look at this X-ray here. This is the normal side, right? So this is the normal side, and this is the affected side here. And look at the femoral head epiphysis of the affected side as compared to the normal. It is reduced it is reduced in dimensions. Moreover, it is also showing some opacities, that what is very suggestive of the classical Perthes disease, right? So like Calvi's Perthes disease, right? So this is Perthes disease X-ray. I think everyone can identify this. This is the typical banana-shaped gametocytes. Yes, Bhuvan, it's okay. It's Perthes disease more perfectly, right? Because we are discussing, this is a case, you can see the epiphysis, you can see the physis, right? So here you can see the growth plate. So it is a case of child, right? And right, so this is Perthes disease. Of course, there are ischemic episodes. There are ischemic episodes which can lead to this uh, necrosis, right? So patches of necrosis. Clear? So it is not the avian classical, but the pathology is somewhat similar to avian, right? So no problem. So this is Perthes disease in children. Then this, I think everyone can answer. This is Plasmodium falciparum. Yes, everyone is right. Plasmodium falciparum. Then in a case of diabetic, there is painless visual loss. And when we have done the fundus examination, we got to have this kind of picture. And this is CRVO, right? So this is classical CRVO, okay? Right? So this is typical CRVO here. And someone wrote, yes, tomato splash appearance, right? So this is CRVO, especially in a case of diabetic patient. Yes, perfect, perfect. Now next question, look at this plane, which is shown by this yellow line. Now, which plane is this? Now, which plane is this? Anyone? Yes, this is actually transpyloric plane, right? So this is transpyloric plane, and trans means through, and of course you can see it is passing through the pylorus of the stomach, right? So that's why it is known as transpyloric plane, and it passes through L1 vertebra. Yes, so please remember L1 vertebra, right? Right. So this is through the L1 vertebra, transpyloric plane. Now, what is this injury actually? You can see a major cut, right? A major cut, and then you can see very small incomplete cut as well. So small incomplete cuts. So these are actually known as hesitation marks, and that is suicidal cut, right? So this is what is known as hesitation marks. So someone is, if trying to slit the wrist, initially he is not able to make a deep cut. So initially he'll have small superficial cuts before finally making the deep fatal cut. So these small marks are known as hesitation marks. Very good, right? So uh, a child from African country has been subjected to a lymph node biopsy, and this is what we have seen. And this is a classical starry sky appearance. And the moment you see any child from Nigeria, think of Burkitt's lymphoma, which is T8 to 14 translocation, right? So 8 to 14 translocation. Now, this is one laparoscopic view, and here you can see this is the uterus, and we can see a fibroid here, right? So this is the fibroid. So this is a case of uterine fibroid, and since it is projecting into the peritoneal cavity, so that is a subserosal kind of fibroid. Right? Now look at this image: a post-COVID diabetic patient, uncontrolled sugar, then respiratory, facial problems, very suggestive of mucormycosis. Right? So I think this doesn't need much of discussion here. So this is mucormycosis. Okay, post-COVID diabetic, sugar not managed properly. Okay, I think everyone can identify these kids with a protuberant abdomen, This is a Vascular, and that is because of less protein intake. Clear? So this is less protein intake. Now, what is this which is marked by this? Now, this area, especially on the left side of the heart, this is actually the aortic knuckle or aortic knob, right? So this is aortic knuckle, and below this we have pulmonary trunk. Later on, still lower down, we have left atrial appendage, and lower down we have the left ventricle, and this is how the left border of the heart is formed. Clear? So this is aortic knuckle or aortic knob. Now this is classical, tense bully of bullous pemphigoid. So tense, this is bullous pemphigoid as compared to pemphigus vulgaris, where we find the flaccid bully, right? So these are tense blisters of bullous pemphigoid. Now look at this post-mortem change, and what actually we are looking here. This is post-mortem hypostasis, right? So the word actually is self-explanatory. Hypo means less, the circulation is less, or stasis means stagnant. So stasis means stagnant. So less circulation, and this is what lead to post-mortem hypostasis, right? So there is stoppage of circulation, and this is not seen on the pressure points. That is very obvious. It is not seen on the pressure points. Okay, so this is post-mortem hypostasis. I think this everyone can identify. This is a classical picture of the butterfly rash, right? This is the classical picture of butterfly rash of SLE. Okay, so this is SLE. So next question. Now, what is being discussed here? What is being discussed here? You can see there are two drugs in discussion, drug A and drug B. So here you have to discuss the drugs in terms of 2 points. Number one, the dose, and number two is effect. So if you look here, yes, Raghu, you are right. Now next question, drug A and drug B, the relationship is, yes, very good, very good. So what we are doing here in this DRC, or dose relation curve, the dose is same, right? So what we can see, the dose is almost same for both the drugs, right? And then the effect varies. Effect is varying, and you can see that the drug A has more effect than drug, right? So we are discussing the efficacy, and it means drug A is more efficacious than drug B. Yes, right. So we are discussing the efficacy here, and we mean that drug A is more efficacious than drug B. Clear? So that is what we discuss here. The maximal effect which is produced by a given amount of the drug, that is the efficacy of that drug. And since the drug A is producing more effect here, so we can say that drug A is more efficacious than drug B, right? So this is efficacy. Now what is being discussed here, just look at, now this is the acetabular cavity, and this is the head of femur. So we can see that the head of femur has moved out of the acetabular cavity, and most importantly we can see here that there is no visibility of the lesser trochanter. So it means there is some sort of internal rotation, so that the lesser trochanter has gone behind the shaft of the femur, and this is a classical posterior hip dislocation. Lesser trochanter is not visible on X-ray. Clear? So please remember this important point, because this suggests internal rotation. Clear? And of course the head of the femur is going behind the acetabulum, so posterior dislocation. Now what is this? This is actually a histogram, right? So this is histogram. What is here? This is orphan any nuclei, and this is in terms of a thyroid swelling. This is suggestive of papillary carcinoma of thyroid. So orphan any nuclei. Clear? Papillary carcinoma of thyroid. Now in this question, what we can see, this is of course a transverse section of the medulla, and in the front we can see this area, right? So this area is all. So what is this area? This is occupied by corticospinal tract. So this is this landmark is actually known as pyramid, right? So this is the pyramids, and since the pyramids are occupied by corticospinal tract, so sometimes these tracts are also known as pyramidal tracts. Clear? So this is pyramids. Posterior to pyramid, you can see inferior olivary nucleus. So this is inferior olivary nuclei, right? So this number 19 is pyramids. Very good, Raghu, very good, right? So this is very. Now just one more X-ray in a case of elderly lady having a fall in bathroom with outstretched hand, and just again we have to look at the distal fragment of the radius first. So if you see here, this is the distal fragment, right? And we have to see the relationship in terms of the hand. So this is the dorsal, this is volar, right? And let us draw the proximal segment as well. So this is somewhere the proximal segment, right? So this means that the dorsal segment has moved backward dorsally. So the moment you have this kind of picture where the distal fragment goes dorsally, your answer will be, what will be your answer if the distal fragment goes dorsally? This concept we have already discussed, but in relation to another entity. Now I just want to check whether you are still remembering the concept or not. So what is the answer here? Yes, everyone is right. I think you must have understood the concept. You have to look for the displacement of the distal fragment. If it is going backward dorsally, think of Colles. If it's going on the volar side, think of Smith, right? So don't make any mistake in that. Now look here, this is again a DRC, and you can see there are two drugs. This is, one is drug B, right? So this is drug B and this is drug A. Now what is true considering this DRC, dose response curve? We have already discussed a little bit of this in the previous questions, but yes, very good, very good. So here what we are checking potency. Very good, Raghu. So we are checking potency. And what is potency actually? Potency is the amount of drug required to produce certain desired effect. Okay. So what is that amount of drug which is needed to produce a certain desired response? So suppose if this is the response we are expecting, then we are giving this much drug of, with this much dose of drug B, and we have to give this much dose of drug A to get this response. So it means we are requiring less dose of the drug B as compared to drug A. So it means drug B is more potent than drug A. Clear? So this is how we check the potency. Whatever the amount of drug that is needed to produce the desired effect. So amount of drug needed to produce a desired effect, that is potency. So smaller the volume of drug needed to produce that drug, the drug will be considered more potent, right? Now I think this is just a repetition. Most of you can easily answer. It just looks like something like a lemon. So this is nothing except epidural hemorrhage, also known as extradural hemorrhage, because of rupture of middle meningeal artery. Now what you can see here in an adult, if you see a vascular patch, this is actually
port wine stain, right? So port wine stain and just 2 P's. In fact, 3. This is the first, this is the second, this is the third. So this is present at birth, right? And persist throughout life. So it will remain forever. Clear? So remember 3 P's for port wine stain. Clear? This is port wine stain. Now what you can see here, this is in this image, you can see that lower legs are not formed fully. So this is what? This is actually phocomelia, right? So you can see phocomelia, and phocomelia has to be remembered in relation to which drug? As a teratogenic effect of which drug? I think most of you can answer it very easily. Yes, it is thalidomide, which was started as a anti-emetic drug, but later on it was realized that it is causing phocomelia, right? So this is thalidomide, right? Please don't mix up phocomelia, absence of bones of the limbs, that is thalidomide. Please, thalidomide, right? This is phocomelia. So that is the end of session. Thank you all for giving your valuable time, and it was really a pleasure teaching all of you, and you were so, energetic, enthusiastic throughout the session. I'm really so happy to be associated with all of you. So with this word, I just sign off. Thank you very much. God bless you. Bye-bye.
So we are very thankful to Kamal Kv sir for his time and this session. I was watching, all the questions are worth, और ये फाइल आपको annotated वाली भी सर हम अभी प्रोवाइड कर देंगे इनको. Just go through this file. बहुत ही important सर के experience के सारे questions थे, and they are going to help you all. And you all deserve to pass. आप सबके सब पास हो रहे हैं. सारे टीचर्स का आपके साथ भरपूर आशीर्वाद है, साथ है. अपने आप को किसी से कम मत समझना, और 6 तारीख को जीत आपकी ही होगी, आपकी ही होगी, आपकी ही होगी. कहते हैं जब तक न सफल हो नींद चैन को त्यागो तुम, संघर्ष का मैदान छोड़कर मत भागो तुम, कुछ किए बिना जय जयकार नहीं होती, मेहनत करने वालों की, कोशिश करने वालों की कभी हार नहीं होती. May God bless you all. Thank you so much for the love and support. Will be sharing file very soon. उसको पढ़ लीजिएगा, आपको जरूर इससे ताकत मिले. Tomorrow there is a drug of choice session जिसकी और डिमांड आ रही थी by Dr. Maruti sir, live 7 PM. I'll be sharing the link. So 30 to 40 minutes drug of choice cover हो जाएंगे उसके अंदर. पूरा साथ आपके साथ. जय हिंद, जय